So we will start with the depressive disorders and antidepressants. So we're going to go through each disorder and go down based on the disorders that you could possibly see. But we'll start with the medications each time. So that way we get the ones out of the way that you guys typically want to see. So antidepressants, we have the brand name and generic name. And some of you may be wondering which one will actually be on the exam. It could depend on what version of the exam you get, which one you need to know. But with the generic name, there are little tricks that you can utilize to understand them. So the antidepressants are going to have INE at the end. Well, the majority of them will have INE at the end. So if you see INE, the likelihood of being an antidepressant is likely high. There's only one other medication class that has INE. One's at the end. So INE is a very, very easy way, as well as the brand name. There are a couple of ways that you can remember those as well. So Zoloft, you're trying to loft their mood above what it would have been. So when you loft things, it raises it. So Zoloft lofts their mood to a higher place than it would have been otherwise. Effexor, it affects their mood in a positive manner, just like we want it to. Wellbutrin helps them feel well. Trazodone, it makes their depression done, or it improves it. And then Celexa helps them select their mood. Lexapro helps them feel like a pro. They feel much better and improved. And the Prozac, again, makes them feel like a pro. So the antidepressants, again, have INE at the end for the generics, and then the brand name, you can have little crafty ways. So if you are starting the medications and the ones that I have provided don't really resonate with you, try finding clever ways to make that connection within your head, especially if you're an auditory and visual person. Tactile, not so much, because it's just words, but you want to have examples practically in your head. So that way, when you see it, it reminds you of what you're looking at. Because a lot of times the medications in the questions are going to be based off the disorder criteria, or they're going to give you the disorder and say what medication would be best for this person in this particular situation. And as I said, most of the time, the generic names are going to have INE at the end, and then come up with clever names to remember the brand names. Because once you understand and utilize different ways to remember things, they come second nature to you. So the disorders associated with them: major depressive disorder and persistent depressive disorder. And you may be wondering, holy cow, how do I separate these two? There is a theme to these things based on the disorder that you're looking at as well. Major depressive disorder is 5 or more symptoms in the same 2-week period. And the number 2 is going to reign important in a second when I make the connection. And so it's a 2-week period represented by a change from a previous functioning with at least one of the following symptoms being met. So you need to have one of these and then 5 of the other criteria. So depressed mood or lost interest in getting less pleasure from things you would have enjoyed otherwise. And then you need to have 5 of these symptoms. So depressed mood most of the day, nearly every day, as indicated by feelings of sadness, feeling empty or hopelessness, or observations from others, such as someone being tearful, down, or isolating themselves. So the depressive disorders are ones that you don't actually have to self-disclose. People can observe the behavior and diagnose it that way as well. The second symptom or criteria: diminished interest or lack of pleasure in all or almost all activities most of the day, nearly every day. So if someone has loss of interest or getting less pleasure from things they would have enjoyed, they would also have a diminished interest or lack of pleasure in all or almost all activities as well. Significant weight loss, change of around 5% of the person's body weight without dieting or trying to lose weight. Insomnia, meaning you don't sleep, or hypersomnia, meaning you sleep more than you would have otherwise. So nearly every day. Psychomotor agitation or retardation. Agitation meaning you're way more energetic and you're flying all over the place. And then retardation meaning it is slowed, or you have slower behavior, reaction, motion, etc. than you would have otherwise. And then fatigue or loss of energy nearly every day. So being tired quickly without much effort. You're waking up, you're already feeling tired. You don't do a whole lot of activities. And you're like, holy smokes, I could totally go to sleep right now. Feelings of worthlessness or for excessive inappropriate guilt or remorse for things they would have done, or that they've done, or they think that they have done. So you feel worthless, or you put so much guilt and shame on yourself that it brings you down even further into the trenches of depression. Lack of concentration or motivation around completing tasks, meaning you may be indecisive, meaning you're not sure what activities you want to do, or it's hard for you to commit to activities. Or if you have a lot of activities in front of you, you just basically shut down and say, nope, I'm good. I'm not going to do this anyway. Recurrent thoughts of death, not just the fear of dying, but wanting to die. Recurrent suicidal ideations without significant plan, meaning you just have thoughts of dying, but you would not execute the plan. Or a serious suicide attempt with plans and means to do so, meaning you want to die, you have thought about how you're going to die, and you have almost planned when and how you're going to actually carry out the deed. And then the symptoms cause a clinically significant impact on the person's functioning and in social, occupational, or other important areas of functioning or parts of their daily life. And that is going to be present in the majority of disorders when you're diagnosing clinically significant impact. So you're going to see that as a theme. And then the episode is not attributable to the physiological effects of substance use or another medical condition. So substance use and or medical conditions are one of the few things that can mimic mental health disorders. Like if you have a severe medical condition, you may have more fatigue. You may have lack of interest of wanting to do things or low moods and all of these things. As well as when you utilize some substances, it can exacerbate depressive type symptoms, such as our depressant drugs. But let's stay on course. The occurrence of major depressive episodes is not better explained by another mental health disorder. So schizoaffective disorder, which is an episode of mania or hypomanic episode behaviors, depressive episodes, as well as some psychosis mixed in, schizophrenia, which is your delusions, hallucinations, disorganized thinking, as well as some negative symptoms, which is a depression associated, schizophrenia form, which we'll get into a little bit later, which is the preform of schizophrenia, delusional disorder. And there's not a manic or hypomanic episode, because if there's a manic or hypomanic episode, we're likely looking at bipolar 1 or bipolar 2 disorder. And then the second depressive disorder, and that's why the number 2 is significant, there are only 2 depressive disorders. So both of them involve 2 in the length of time of the criteria. So persistent, meaning that is persist, and something that is persisted or that is persistent is long-term and is going over time. So depressed mood for the most of the day, for more days than not, as indicated by either a subjective account of the symptoms, aka they're self-disclosing, or someone's observing for, you'll never guess, 2 years. So you either have a disorder for 2 weeks or more, or 2 years or longer. And there happens to only be 2 depressive disorders. So the number 2 reigns pretty heavy when it comes to the depression. And then if it's a children or adolescent, or child or adolescent, it's at least 1 year. So that is where it gets kind of tricky, but children and adolescents have less length of time for diagnosing for some disorders. So the criteria for persistent depressive disorder is going to be very, very similar to major depressive disorder. So the length of time is going to be the major reigning here. So poor appetite or overeating, insomnia, again, not sleeping, or hyposomnia, oversleeping, low energy or fatigue or easily fatigued, low self-esteem, poor concentration or not being able to decide on activity that you'd like to do, and feelings of hopelessness. So during the 1 year or 2 year period, 1 year for children and adolescents, 2 years for adults, of the disturbance, the individual has not been without criteria for more than 2 months. Another 2, isn't that ironic? So for major depressive disorder, it's 2 weeks or longer. Persistent is 2 years or longer. And with persistent, they can go without symptomology of depression for no longer than 2 months. And criteria for MDD may consistently be present for 2 years. So MDD can be a feeder to persistent if it goes that way. So there's not been any manic or hypomanic episodes, and criteria has not been met for cyclothymic disorder. So mania or hyperomania would be our bipolar 1 and bipolar 2. And then cyclothymic disorder is a less version of bipolar. It is less severe in the symptoms of depression. So depression is less severe in the cyclothymic disorders. So the disturbance is not better explained by persistent schizoaffective disorder. Again, schizoaffective is a mood disorder such as bipolar disorder or MDD with some psychosis involved with it. The disturbance is not better explained by schizophrenia, delusional disorder, or other specified schizophrenia disorder, a schizophrenia form as well. The symptoms are not attributable to a physiological effect of a substance or a medical condition. And as I said, substance use or medical conditions are one of the few things that can mimic our depressive disorders or mental health disorders in general. And the symptoms cause a clinically significant distress or impairment in social, occupational, or other important areas of functioning. So now we're leaving the town of depression and going into our town of anxiety. So the anti-anxiety medications, we have the brand name again and the generic name. In the generic name, we can always find some themes and clever ways to remember. You're going to have Lamb and Pam at the end of it. Why? Because Pam needs anxiety medication to handle her lambs. So if you notice, almost every single one of them has Pam or Lamb. And then the brand name, there isn't really a good brand name with theme with these, but if you're in the mental health field, you probably have seen these medications or have heard of the medications in passing. So we have Xanax, Klonopin, Valium, Ativan, Buspar, Librium, etc. So if you see Lamb or Pam at the end of the generic name, likely going to be anti-anxiety medications. So the disorders that are associated with these have a theme just like our depressive disorders, which is stinking cool. So generalized anxiety disorder is where someone is anxious in general. So there's no real theme of why they're anxious. Anxiety just breeds within that. So someone has excessive worries more days than not for longer than 6 months. So 6 months is going to be our theme without all of our anxiety disorders, with the exception of one of them, but I'll get into that a little later. So you must have 3 or more of the following symptoms. So only 3 of these. So restlessness or feelings of being on edge, ready to react at any given moment, at any given time, being easily fatigued, which if you remember in the depressive disorders, this is kind of a carryover. So depressive disorders and anxiety disorders have a lot of similarities, more than you might have thought. So difficulty concentrating or thoughts moving in multiple directions, not being able to keep focus or bumping from task to task to task. Irritability or shouting at people. Muscle tension, meaning your body is getting more tense or you are ready to react in fight, flight, or freeze. Or sleep disturbance or not being able to sleep or oversleeping. So the anxiety or worry is a clinically significant impact on the person's life, and the disturbance is not better attributable to another mental health disorder or substance use intoxication or withdrawal. Which the next anxiety disorder is social anxiety disorder. Key emphasis on social, because social interactions are going to be the key center of the anxiety. So it is a marked fear or anxiety about one or more social situation in which the individual is exposed to possible scrutiny by others. So again, if someone's in a social situation where they can be just scrutinized, criticized, or anything like that, it is going to exacerbate excessive fear. So an example here is social interactions, having a conversation with someone new or having conversations with somebody that they've only met a certain amount of time, being observed, whether it's eating, drinking, or anything like that, or performing in front of people, such as giving a speech during an ASWB study group like now. Like if I'm experiencing excessive anxiety and I just like run off the mic and say, I can't handle this, or I don't know what these people are thinking. Are they actually understanding it? Are they getting the clever ways of remembering these things? Wow, was that a good statement or not? Anything like that, just running through the mind and clinically impacting it in any way, shape, or form is going to be our social anxiety. So in children, the anxiety must occur in peer situations, not during interactions with adults. Why is that? Stranger danger. We don't want kids to be comfortable talking to people that they don't know. So it must occur in peer situations. Why? Because peer-to-peer is more common than an adult and a child. There's a stratification or power and privilege type dynamic there. So the individual that he or she will act in a manner that will negatively impact their ability because they feel like they're being evaluated in some way, shape, or form. So they have a fear of being evaluated or scrutinized or criticized in some way. If they show anxiety symptoms, they feel like they can be negatively viewed as well because people shouldn't have fear at all, or they shouldn't worry, and they should have a perfect record, etc. So some of you in the study group right now may be like, man, I may have like social anxiety when it comes around testing or talking to people about this exam based on the fact that some people that I know have already passed it. I haven't passed it yet, and I don't really want to say it, or I don't want to say the amount of times I've done it. But that is okay. You just have to know the environments that you're going to go in are going to impact how you view and situate with yourself. So the social situation almost always provokes fear or anxiety in some way. And again, children are a little bit different in this. The fear or anxiety may be expressed by crying, tantrums, freezing, clinging, shrinking, or failing to speak in social situations. Children don't really have the vocabulary or capacity to be able to be like, wow, I'm super anxious in this situation because X, Y, or Z. So children tend to express themselves in more action or behavioral ways than systematically and cognitive ways. Go figure. So the social situations are avoided or endured with intense fear or anxiety. So someone can have social anxiety, they just push through the behavior based on the fact that that's what they expect to happen with and for them. So the fear and anxiety is out of proportion to the actual threat posed by the social situation. So that's where some people will say, like, wow, this is going to be the worst thing that could possibly happen to me. I could totally die in this situation. No one will like me. I'll just have to go move into a hut in the woods, etc. And the fear, anxiety, or avoidance is persistent with typically, you'll never guess the length of time, 6 months or more. Our anxiety disorders are super duper relevant to our 6 months or more. So if you see 6 months or more and there's anxiety symptoms, it is likely going to be an anxiety disorder. Why? Because all of the anxiety disorders have 6 months or longer. And then separation anxiety, key emphasis on separation, is when somebody's being separated from somebody, they are experiencing anxiety based on the fact that there's perceived or actual separation from someone. So developmentally inappropriate or excessive fear or anxiety concerning the separation from those the individual is attached, as evidenced by at least 3 of the following. So recurrent or excessive distress when anticipating or experiencing separation from home or from a major attachment figure in their life does not have to be mom, dad, or caregiver. It could be just someone that they view significant in their life. Persistent and excessive worry about losing a major attachment figure in their life or about possible harm to them, such as illness, injury, disaster, or death, etc. Any negative impact that they feel that they don't have control over, and that's going to impact that significant caregiver from being in their life in some way. Persistent or excessive worry about experiencing an unexpected event, so them getting lost, being kidnapped, having an accident, etc., that causes separation from their attachment figure. So it's a two-prong. You're afraid of your attachment figure being put into a situation that could separate them from you, or you're being put into a situation that could cause separation from that caregiver based on your actions. Or persistent or excessive refusal or reluctance to go out, go away from, to school, to work, or anywhere away from the attachment figure because of fear of separation in some way, because you feel like you're not going to be protected or your caregiver or significant person attachment figure is not going to be there. Persistent and excessive fear of or reluctance about being alone or without their major attachment figure at home or in other settings. Persistent, reluctant, or refusal to sleep away from home or go to sleep without being near their major attachment figure. Repeated nightmares involving the theme of being separated from their major attachment figure. And then repeated complaints of physical symptoms, headaches, stomach aches, nausea, and or vomiting. And the key emphasis here, when they are separated from their major attachment figure. And I'm emphasizing this because there's a huge anxiety disorder that involves a lot of physiological reactions. So I want to pinpoint this so that we don't get confused when it happens. And then the fear anxiety, or avoidance is persistent at least 4 weeks in children, and you will never guess the length of time for those they're adults, at least 6 months or longer. So that's the thing. 6 months or more is going to be huge in the anxiety realm. The disturbance causes clinically significant impact or stress in social, occupational, or other areas of functioning, and the disturbance is not better explained by another mental health disorder, such as refusing to leave home because of excessive resistance to change, such as autism disorder, delusions, or hallucinations concerning separations, and a psychotic disorder. So if someone's exhibiting psychosis, it cannot be an anxiety disorder. Why? Because it's a psychotic episode, such as a delusional disorder, brief psychotic disorder, schizophrenia form, and or schizophrenia. Or if you're going to be looking at the personality disorders, you're looking at our schizotypals or schizoid disorder. And then another one, panic disorder, key emphasis on panic, because they are in a panic when they have a panic disorder, which causes panic attacks, and then they fear having another attack. So someone will have recurrent, unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort, with the onset sometimes being unknown. Key emphasis on sometimes being unknown. So there's not always going to be a trigger point of when someone has a panic attack. It could just simply happen out of nowhere. And the number of symptoms or criteria that you have to have is 4 or more of the following of these. And this is the disorder that I was talking about, physiological reactions or body sensations in some way. So palpitations or heart palpitations, such as pounding heart, quick heartbeat, sweating, trembling or shaking, shortness of breath, SOB, shortness of breath, feelings of choking, chest pain or discomfort, nausea or sensations to vomit, feeling dizzy, chills or overheating type sensations, numbness or tingles throughout the body, derealization, meaning like they feel like their situation's not real and they're outside of their body and that they can control the actions, but nothing's happening in their body, fear of losing control, and fear of dying. So if anyone was experiencing any of those symptoms, they would probably panic and feel like they're having a heart attack, stroke, etc. So that is what someone is going through in that given time. And this is where the anxiety disorders kind of stray away from each other, because this one is kind of tricky because you have to have at least one panic attack within the last month. So this one's not 6 months or longer. It is not also mental as well, because it's physiological sensations and it's not 6 months or longer. So must have one or both of these. So persistent concern or worry about additional panic attacks occurring, or fear of having a heart attack, or a significant maladaptive change in behavior to avoid having a panic attack, or perceived ability to prevent one, such as avoiding exercise because it raises heart rate, and as well as situations that you feel that have triggered a panic attack. You may avoid situations even though it's not associated to anything. You just believe that it is. The symptoms are not better described by another psychological disorder or substance use intoxication or withdrawal, because if someone is doing a stimulant drug, such as cocaine, crack, methamphetamines, you are likely going to have these sensations within the body. So if someone is intoxicated on a stimulant drug, you are likely going to believe that you're having a panic attack. But it's not a panic attack or panic disorder based on the fact that you were intoxicated on the substance. Now moving down to the mood stabilizers, or our mood disorders. And some mood stabilizers can also counteract as antipsychotics. So I have labeled AP next to the ones that are antipsychotic medications as well. So if you see AP next to it, such as Haldol, Risperdal, Latuda, and Abilify, just know those are antipsychotics, and their generic name is going to be down below with the antipsychotic disorders. And with the mood stabilizers, I don't really have any clever way to remember the generic name, and there is only one on the brand name side, Depakote, because it coats the mood and makes it look different. So just knowing and memorizing these mood stabilizers, because there's not too many of them, will be a lot easier than trying to find clever ways. So lithium, Depakote, Lamictal, valproic acid or depakine. And then, like I said, the antipsychotic that can also be mood stabilizers, Haldol, Risperdal, Latuda, and Abilify. So common disorders within this are going to be our bipolar 1 and bipolar 2. So bipolar 1 disorder most commonly has manic episodes. So if you hear a manic episode, likely going to be bipolar 1. And if you hear hypomanic episode, it's likely going to be bipolar 2. So bipolar 1 is when someone will experience a manic episode and often accompanied by an episode of depression, but it does not require an episode of depression. It can have one, but it does not require it. And you're going to say, why is that relevant? Because bipolar 2 requires a depressive episode. So manic episode is described as 3 or more of the following symptoms and must be present for 1 week or more. So 7 days or more. So inflated sense of steam or grandiosity, thinking that they are the second coming, that they have tiger's blood, just like Charlie Sheen thought. Decreased need for sleep, feels like they've been rested after only 3 hours or not sleeping for days in a row. More talkative than normal or feeling pressure to have conversation with people. So they're just chatterboxes, ton of things going through the mouth. Their mouth is moving faster than their thoughts are, and they're just going flight of idea. Like I said, their mind is just going 100 miles an hour. Their thoughts are running through their head. They can't slow them down, and they can't even really comprehend what is going on. It's just like flashes of things going through their mind. Distractibility finds it difficult to stay on track, doing multiple tasks and not ever really completing them, and just wanting to get things done, but being frustrated that they're not able to handle it. Increasing goal-oriented activities, meaning that they want to do 100 bajillion things or they want to start 12 different careers, but they're not able to ever handle or stable it down to finish one of those. So having a lot of goals in mind, but not really having the motivation to finish them. Excessive involvement in activities with high potential for painful or negative consequences. So spending great deals of money that they don't entirely have, engaging in a lot of sex or unprotected sex, or sexual encounters that could potentially be dangerous. Substance use or foolish business ideas, etc. Anything that could potentially put them at harm that they otherwise would not have engaged in if they were not in a manic episode. And then symptoms have a clinically significant impact on the client's functioning. And that is going to be huge because hypomania or bipolar 2 does not require to have a clinically significant impact on the person's functioning. And what is a clinically significant impact in this realm? Hospitalizations, they may be exhibiting self-harm or homicidal ideations, homicidal attempts, suicide attempts, etc. An easy way to remember the criteria, because A through G is pretty hard to remember sometimes, is dig fast. So D, distractibility. I, increased goal-oriented activity. G, grandiosity. F, flight of idea. A, activities that could be risky. S, sleep disturbances. And T, talkativeness or feeling that they have to be talkative. And that's going to be related to both of the disorders that we look like. And you're like, well, I thought hypomania was totally different. Not so fast. So hypomania can also be associated with bipolar 1 disorder, but they would have more manic episodes because that clinically significant impact piece has to be present within that situation. So hypomania is at least 4 days or longer. And manic episodes were a week or more or 7 days or longer. And the criteria is absolutely the same. So inflated sense of steam or grandiosity, thinking more of themselves or that they're the second coming, or that they are better than every single person in their presence. Decreased need for sleep, feeling rested after 3 hours, not sleeping for days in a row. More talkative than normal, feeling like they have to talk to everybody, not being able to keep up with the things that they're saying, and just going on and on and on about things. Flight of idea, having a ton of things go through their mind, or where they can actually slow them down and comprehend them. Distractibility, not being able to finish things, starting a ton of things, and not being able to entirely stay focused, or they may be engaged in an activity and they may be in la la land. Increasing goal-oriented activities, again, starting many different tasks that they otherwise would have not done. and not even ever really finish them. Excessive involvement in activities with high potential for painful or negative consequences, spending money, engaging in a lot of sex, substance use, foolish business ideas, fighting with people, etc. And the biggest difference between mania and hypomania is it does not require clinically significant impact, or it does not have a clinically significant impact on the person's functioning. So hypomania is the person that tends to be better off for having hypomanic episodes, and they're the client that's like, dude, I totally enjoy my episodes, and they're actually more productive and they get things done eventually. So bipolar 2 disorder requires someone to have an episode of depression. And as if you remember, bipolar 1 did not require an episode of depression. Bipolar 2 does, and it is 4 days or longer. Why? Because bipolar 2 has hypomanic episodes. And the criteria is going to be entirely the same. So inflated sense of esteem or grandiosity, decreased need for sleep, sleeping for 3 hours and feeling fully rested, going days without sleeping, more talkative than normal, feeling like they have to talk to everybody, or there's a lot of things going through their head they want to talk about, but they don't really talk to people, flight of idea or thoughts that may run through their head and they can't really slow them down, ton of things that they want to get done, distractibility, increasing goal-oriented activities, excessive involvement in activities at high risk for harm or negative consequences, and again, does not have a clinically significant impact on the person's functioning. So again, bipolar 1, most likely manic episodes, bipolar 2, hypomanic episodes. So quick little breakdown between the difference between hypomania and mania is the duration of symptoms and its impact that it has on someone's life. So mania is 1 week or longer, bipolar 1 week or longer, hospitalization or negative impact on someone's life. And a couple of examples of this was Britney Spears when she was dangling the baby over the balcony. She was shaving her head. She was spending a ton of money. Or Charlie Sheen when he was doing a ton of drugs, saying he had tiger's blood. He was fighting people. He was gambling, doing a whole bunch of excessive activities that he would have not done now that he is stable. Hypomania, 4 days or more. And if you want to think about it, bipolar 2, 2 times 2 is 4. So hypomania is half of what it would be because it does not have a clinically significant impact on someone's functioning. So someone is overproductive at work, gets fixated on task, and often more productive with their time when they're in a hypomanic episode. But they find it difficult to do one thing at a time and always gets involved with multiple things, or gets involved in too many things that can have a negative impact on their mental health in general. So those are going to be our mood disorders. So now rolling down our medications or ADHD medications, brain name, generic name, and the generic name does have a trick here. They all have feta and fiend in the middle because people fiend for their feta cheese, which makes it hard for them to focus. And then the brand names don't really have a tricky thing that you can do, but if you know ADHD, you've seen these meds, or in public, you've heard these meds as well. Adderall, Concerta, Ritalin, and Vyvanse. And as I said, most generic names have feta and fiend in the middle because people fiend for their feta cheese. And the disorder that is associated with the ADHD medications, ADHD, attention deficit hyperactivity disorder. So there are two types, inattentive and hyperactive. And they all have the same amount of criteria that you have to have, 6 or more symptoms for children of the ages of 16 or younger, and then 5 or more symptoms for adolescents 17 and older. So symptoms of attention have to be present for at least 6 months and inappropriate for the developmental age for the person that is involved. So keep that in mind as we're going through these. So often fail to give close attention to details or make careless mistakes in schoolwork, at work, or with other activities in general. Often have trouble holding attention during tasks or playing activities. Often seem like they're not listening to the rules or that they're in their own land. Often seem like they listen to others while being spoken to. And they want to speak, but they're not listening to people. So they just like act like they're listening so that way they can jump in and say what they do. So they don't listen to people when spoken to. Often have difficulty with organization or organizing tasks and activities at the same time. Often avoid things that they dislike or are reluctant to do tasks that require a lot of mental effort over a long period of time, such as schoolwork, work, house chores, playing games, etc. And they often lose things necessary for tasks such as schoolwork materials, pencil, paper, homework, house key, instructions, phone charger, mics, passwords, etc. And they often get distracted by things around them easily. Squirrel. And they are often forgetful in daily tasks. So if you tell them something, then you may not be able to do that as well. And then the other type is hyperactivity and impulsivity. So, same amount of symptoms, 6 or more for 16 years old and younger, and then 5 or more for 17 and older. And hyperactivity and impulse symptoms must be present, same amount of time, 6 months or longer, and cause impact that is disruptive and inappropriate for their developmental level, meaning it disrupts what they're doing and it has a negatively impact on their ability to engage in activities or sustain activities. So keep that in mind as we go through it as well. Often fidget with or tap their hands, feet, or simply squirm in their seat. Often leave their seat in situations when remain in their seat is expected. Often runs about or climbs in situations where it is not appropriate. Adolescents or adults, this can be limited to feeling restless or fidgeting all about. Often are unable to play or take part in leisure activities quietly, or bounce from task to task and get bored very, very quickly. Often seem to be on the go, acting as if driven by a motor. So they're all over the place. They have energy like no other. So often excessively talk or without much direction, they continue talking, they're bouncing from things to things, or what they're saying is not entirely making sense. They often blurt out answers even before the question is finished because they want to get the job done and get to the next task. Often has trouble waiting in line for their turn, and often interrupts or intrudes on others' conversations, games, etc., because they want to be involved in the activity and they want to have that sense of connection with people. And in addition to the following symptoms, these conditions must be met. So several inattention or impulsive activities were present before the age of 12 years old. So they can have all of the symptoms, but it must be present before 12. Several of the symptoms are present in 2 or more of the settings. So if something is done only at school, but not at home or in any other activity, it's very difficult to diagnose it that way, such as home, school, work, with friends, or relatives. There's a clear evidence that the symptoms interfere with or reduce the quality of the person's social work or any functioning in general. The symptoms are not better explained by another mental health disorder, such as mood disorder, anxiety disorder, dissociative disorder, or personality disorder. And the symptoms are not happening as a result of the psychotic disorder or schizophrenia. So based on the types of symptoms, there are 3 types of presentations that you can see happening in the situation. So the combined presentation means that they have enough symptoms for both inattentive and hyperactivity impulsive, and they are happening in the last 6 months. So they have both disorders in the combined, and then predominantly inattentive is where someone has enough criteria for inattention, but not for hyperactivity and impulsivity. And again, 6 months is our target. Predominantly hyperactivity and impulsivity. So they have enough criteria for hyperactivity and impulsivity, but not for the inattentive type. And this is for 6 months or longer. So now moving into our last little bit of meds and disorders. So the antipsychotic disorders, and again, AP for short, and we've seen some of these in our mood disorder section, but let's peel them back. So the brand name and generic name, the generic name has a theme just like every other single one, but it can be kind of tricky because the depressive disorders had the same theme, but these ones sound a little bit harsher. So some of them have INE at the end, as well as done at the end, because when you take your antipsychotic med, you are done. Stabilizes you and calms you right down. So this is the tricky part. If you see INE at the end, it's either going to be our antidepressant or antipsychotic disorder. But risperidone sounds a lot more intense than some of the antidepressants that we saw before. In the brain name, there's no really clever name, but when you see them, you'll know them. Haldol, Vraylar, Risperidol, Thorazine, Invega, Geodine, Clozaril, and Abilify. And as I said, INE at the end are done, because when people take these meds, they are done. And the disorders that are associated with this is our schizophrenia spectrum. So our brief psychotic disorder, our schizophreniform, and schizophrenia. And you may be wondering, what the heck is the difference between all of them? And there's not a whole lot of difference besides the length of time that we're looking at. So brief psychotic disorder, key emphasis on brief, is going to be a brief amount of time. So it's a thought pattern disorder in which the person will experience short-term gross motor deficits in reality testing manifested by at least one of the following. We have delusions, which are false beliefs that are not based in reality, and the person refuses to give up even when they are presented with factual information. You could show somebody something factual, and this person is entirely going to find a reason not to believe it. Hallucinations, auditory, meaning you're hearing it, visual, meaning you're seeing it, tactile, meaning you're feeling it, olfactory, meaning you're smelling the factory, things that are not actually there or other people cannot hear, see, feel, or smell. And then disorganized speech is incoherent or irrational content. So someone is tangential or speaking about multiple tasks that don't align or blend together. The theme of speech is not entirely connected, or the things that the person is saying are not entirely realistic. So let's say Phil was doing a DSM-5 and Meds study group, and then he started talking about what the Penguins were doing outside his apartment. And then he was like, wow, are you going to bet on the football game? And then goes back to the DSM-5 and Meds, and he's like, wow, yeah, I really need to clean my sink over there. And yeah, did you see what my roommate just did? Not entirely connected at all. And someone would say, what in the heck is this guy even talking about? As well as disorganized or catatonic behavior, which is repetitive, senseless movement or adaptive a pose which may be maintained for hours at a time. The individual may be resistant to efforts to move them into a different position, or will assume the new position for hours, and symptoms are not better explained by a depressive disorder or psychotic features, because if someone is depressed and not moving and unmotivated and all of these things, it's probably going to be more of a depressive disorder. And if people get super depressed or have severe depression, they can have psychotic features or hallucinations, delusions, etc. Bipolar disorder or psychotic features. So if there's a mania and hypomania in there, more likely mania. Or another psychotic disorder such as schizophrenia, meaning it's a longer length of time, or catatonia, and is not attributable to a physiological effect of a substance or another medical condition. So if someone is withdrawing from a substance, they're likely going to feel depressed and maybe delusional and hallucinating and exhibiting some of these behaviors as well. And the length of time here, I said, was brief, so 1 to 30 days. So I say less than 30 days because it's a brief amount of time. If someone asks you, hey, I'm going to be here for a brief time, likely going to be less than a month. So now we're going to walk into schizophrenia form, and it is the pre-form of schizophrenia. Why is it the pre-form? Because it comes before schizophrenia based on the length of time. So it needs to have at least two of the following criteria. With at least 1 month, aka it has exceeded brief psychotic disorder, but less than 6 months, because schizophrenia is 6 months or longer. And the symptoms 1 to 4 are considered positive symptoms. And I always say, think of positivity. Your mind is overactive and excited. And symptoms 5 to 8 are considered negative symptoms. Think of an negativity, it brings you down and you don't feel like doing a whole lot. So our positive symptoms are delusions, hallucinations, disorganized speech, or grossly disorganized or catatonic behavior. So again, our delusions are going to be false beliefs that are not based in reality, and the person refuses to give them up. And again, even though that factual information is thrown in front of the face, they're like, Elia, get that witchcraft away from me. Hallucinations, auditory, hearing, visual, seeing, tactile, we're feeling it. Olfactory, we're smelling the factory. Disorganized speech, again, saying things that don't make sense, using made up words that have no meaning, and or that tangential speech that the person skips from topic to topic with no common theme. And then our grossly disorganized or catatonic behaviors are repetitive, senseless movements, adopt and a pose which that can be maintained for hours. Someone moves them into a different pose, they adopt that pose as well. Pacing, walking in circles, writing excessively, repeated movements with no rhyme or reason, as well as their mind is turning and they're saying and doing things that they otherwise wouldn't. Our negative symptoms, it's going to be our lack of energy, poor hygiene and lacking of grooming, loss of interest in things that they would have enjoyed, and withdrawal from family, friends, or activities that they otherwise would have been in, or that they feel paranoid that the people are out to get them in some way. And again, schizophrenia form is going to be less than 6 months, but 1 month or longer. In schizoaffective disorder and bipolar disorder with psychotic features has been ruled out because either one, no major depressive or manic episode occurred concurrently with the active phases of symptoms, or if mood episodes have occurred during active phase symptoms, they have been present for a minority of the total duration. And the disturbance is not attributable to the physiological effects of a substance or a medical condition. And then, as I said before, more than 1 month, less than 6 months for the length of time. And then taking us all the way home is our last disorder, schizophrenia. And the criteria has at least 2 of the following symptoms. And you guessed it, 6 months or longer. Symptoms 1 to 4 are considered positive symptoms. And as I said, high energy or the mind is going quickly. Symptoms 5 to 8 are negative symptoms, low energy, no progression, negativity drags you down, positivity rise you up, and you feel motivated to do things. And they are the same exact criteria as before, but let's go through them just for the semantics. Delusions, false beliefs that are not based in reality, and the person refuses to give them up even when presented with that factual information. And the hallucinations are the auditory, hearing, visual, seeing, tactile, feeling, olfactory, smelling that factory that are not actually there, other people cannot experience with you. Disorganized speech, saying things that do not make sense, using made up words that have no meaning, or that tangential speech where we're bouncing from topic to topic with no theme. Grossly disorganized or catatonic behavior, repetitive, senseless movements, adopt and a pose in which may be maintained for hours. And if someone moves you, you maintain that pose for hours as well. That pacing, walking in circles, writing constantly, or repetitive actions that have no rhyme or reason, or the person does not know why they are doing them. And then our negative symptoms are lack of energy, poor hygiene, a lack of grooming, loss of interest in things that they would have enjoyed, and withdrawal from family, friends, and social activities, which could be based in paranoia where they feel that the people are out to get them or that they cannot trust people in general. In a significant portion of the time since the onset of the disturbance, level function in one or more major areas such as work, interpersonal relationships, or self-care have been below the achieved prior to the onset of symptoms. So the schizophrenia symptoms have had a negative impact on the person's life in some way. Schizoaffective and bipolar disorder psychotic features have been ruled out based on the same way that schizophrenia form was. No major depressive or manic episodes occurred concurrently with the active phase of symptoms, or if mood episodes have occurred during active phases, then they have been present for a minority of the duration, and the disturbance is not attributable to the physiological effects of a substance use or another medical condition in some way. So those are all our medications, or the most common ones, as well as the disorders associated, our depressive disorders, our anxiety disorders, our mood disorders, our ADHD, and then our schizophrenia spectrum. Question 1. A social worker at an outpatient clinic is completing an intake assessment with a 35-year-old male who reports finding it difficult to handle all the responsibilities in his life. The man reports that he's been working at his current job for 5 years and then he always feels like he is going to be fired. The man reports he often feels the urge to hurt people and that when he is not at work, he will lock himself in the house to prevent himself from acting on his thoughts. The man reports he was previously hospitalized 1 year ago due to experiencing feelings of hopelessness. What is the most likely medication to improve the man's situation? A. Clozaril. B. Valium. C. Depakote. D. Celexa. And when you have your answer, type the word pumpkin into the chat. Opening the polls. Twenty more seconds. Shutting down the polls. The majority think it is C. Second place is B. Third place is D. Fourth place is A. Let's look at it. So we have a social worker, outpatient clinic, completing an intake assessment with a 35-year-old male, and he is reporting difficulties with handling all of the responsibilities in his life. So he's overwhelmed. He's been working at his current job for 5 years. Any length of time, hop on top of it because it'll paint the picture for what is going on. So he's been experiencing the symptoms for 5 years and he always feels like he's going to be fired. So there's some type of maybe paranoia or anxiety because if you've been doing it for 5 years and you've not been fired, probably some severe paranoia or anxiety. He reports he often feels the urge to hurt people and when he's not at work. So he has some maybe delusionals type stuff or homicidal ideations. He will lock himself in the house to prevent him from acting on the things. And the man reports he was previously hospitalized 1 year ago. So 1 year ago, he was put into the hospital because he had some depressive symptoms. What is the most likely medication to improve the man's situation? So Clozaril is going to be our antipsychotic. Valium is going to be our anxiety med. Depakote is going to be our mood stabilizer. And then Celexa is going to be our depression. Keyboard has gotten away from me. So quick review. We are an outpatient clinic, so that's going to be relevant because it's going to be long-term care. Intake assessment, meaning the first time we're meeting this guy, 35-year-old male, finding it difficult to balance his responsibilities. He's been experiencing this for 5 years. He's fearing that he's going to get fired. He feels like he's going to hurt people, and he was previously hospitalized. So at this given moment, we're going to rule out Celexa because it's a little more intense than depression because he has homicidal ideations, maybe anxiety or paranoia, and he was hospitalized for the behaviors of hopelessness, but he did not say he wanted to kill himself in any way, shape, or form. So we can have antipsychotic, anxiety, or mood stabilizer. So we're going to rule out anxiety because there's only one piece of anxiety. But if the anxiety's been there for 5 years, it's probably a little bit deeper than anxiety and maybe more along the lines of paranoia. So we have some episodes of paranoia here. Has the urge to hurt people. So is that kind of delusional or a mood disorder type symptoms? And he'll lock himself in the house to prevent himself from doing it. So it's a little bit of excessive and over the top to want to do it. And the key details here is that he has urges that he's going to be fired, so maybe paranoia, and that he has the urges to hurt people. So at this given time, we're going to rule out Depakote or a mood stabilizer because it may look like he's exhibiting mania, but he may also be having a psychotic episode that he has paranoia, he has delusions of wanting to hurt people, and he was hospitalized for being hopeless, and he's locking himself away to get the job done. So we're going to be looking at Clozero because if you're having the urges to hurt people and paranoid to be fired and this never happened, even though you have factual information of 5 years of employment to the contrary of your thought, and again, the key emphasis is against the factual information. So the key details are there. And the best answer is going to be Clozaril or an antipsychotic. So that's how we look at that question in particular. Question 2. An emergency department social worker is completing an intake assessment with a 40-year-old female who reports feeling like nothing will ever get better. The woman reports that she has been finding it difficult to keep her thoughts straight and that there's not enough time in the day to accomplish everything she would like to. The woman reports she's been avoiding her friends since she feels like they're going to make fun of her or hurt her in some way. The woman reports having nightmares and constantly worrying about everything. Which medication is the doctor most likely going to prescribe the woman? A. Clozapine. B. Clozapam. C. Bupropion. D. Depakote. And when you have your answer, type the word tricky into the chat. Opening the polls. Twenty more seconds. Slapping the polls shut. The majority think it is B. Second place is A and C. Third place is D. Let's look at it. So we have an emergency department social worker completing an intake assessment, first time us seeing them, 40-year-old female, and feeling like nothing will ever get better. She's been finding it difficult to keep her thoughts straight and feels like there's not enough time in the day to accomplish everything. And she has been avoiding her friends because she feels like they're going to make fun of her or hurt her in some way. And the woman's having nightmare and constantly worrying about everything. So now let's look at our medications. So clozapine, antipsychotic, because clozapine, INE, and it sounds a little more intense, is going to be our antipsychotic. So that's going to be our clozaril. Now clozapam, Pam and Lamb, anti-anxiety. Why? Because Pam needs anxiety medication to handle her lambs, which clozapam is going to be our Klonopin, bupropion. It doesn't really have a theme here, but if we know it, it's going to be our depression. Why? Because that is Wellbutrin. And then Depakote is not like the others, and that is going to be our mood stabilizer because it's not a generic. It is a brand name. So quick review. Emergency department social worker, intake assessment, first time seeing her, 30-year-old female. She feels like nothing's going to get better. She's finding it difficult to keep her thoughts straight. So flight of idea, not enough time in the day to get everything done. She's avoiding her friends. Why? Because she feels like they're going to make fun of her in some way. So some anxiety. And then one's having nightmares, so sleep disturbance, constant worry, so flight of idea again. So keep that in mind as we look at it. So at this time, we're not seeing any psychosis, no delusions, no hallucinations, nothing like that. No catatonic behavior, no positive or negative symptoms. We're not seeing any depression. We're seeing lack of like sleep disturbances and lack of concentration, but there's no hopelessness, no weight loss, no low mood, no depressed mood, no low self-esteem, anything like that. So are we looking at anxiety here? Are we looking at mania or hypomania? So in this particular situation, we feel like someone's things aren't going to get better, some hopelessness, difficult to keep her thoughts straight, so lack of concentration, and some feeling some pressure, and she feels like she's going to be made fun of. So that's kind of more anxiety, sleep disturbances, and constantly worrying about everything. So we're going to rule out our mood stabilizer because it's not talking about mania or hypomania, and it's not talking about depressive episodes or anything like that. So in this particular situation, we're going to look at clozapam and anti-anxiety. Plus, you have to keep in mind that we're in the emergency department, so we're going to stabilize and get her out of the place rather quickly. And most of these other medications are long-term, and we'd have to monitor them in some way, shape, or form. So that's how we'd look at that question in particular. So question 3. The social worker at a community mental health agency is meeting with the 28-year-old male upon discharge from a hospital for a suicide attempt. The man reports feeling like, regardless of what he does, that he will never be good enough. The man reports that his mother recently died and that his girlfriend broke up with him last month. The man reports utilizing alcohol to cope with all of his stressors. The man would like to find ways to improve his mood and to stop losing everything. What medication would be best supplement his treatment? A. Effexor. B. Ativan. C. Haldol. D. Adderall. And when you have your answer, type the word coffee into the chat. Opening the polls. 20 more seconds. Slapping the poll shut. The majority think it is A. Second place is C. Third place is B. No one thought D. Let's look at it. So, social worker, community mental health agency, 28-year-old male, and he was recently discharged from the hospital for a suicide attempt. Feels like regardless of what he does, he doesn't feel good enough, low self-esteem. Reports his mother recently died and his girlfriend broke up with him last month. Any length of time, hop on top of it. Why? It'll give us context of what the heck's going on. Man reports utilizing alcohol to cope with all of his stressors, so some substance use in some way, shape, or form. And he'd like to find ways to improve his mood and stop losing everything. So let's break down our medication. So Effexor can affect our mood positively. Depression, Ativan, drive that van, it makes us anxious. Anti-anxiety. Haldol is going to be our antipsychotic. And then Adderall, we're looking at ADHD. Quick review. Community Mental Health Agency, 28-year-old male. He's getting released from the hospital for a suicide attempt. He feels like regardless of what he does, he's not good enough. His mother recently died and his girlfriend broke up with him last month. He's utilizing alcohol to cope with the stress. He wants to find ways to change his behavior. What med is going to supplement him really, really well. So at this time, we're going to rule out Adderall because why? He doesn't have ADHD symptomology at all. He's not saying inattention. He's not saying hyperactivity. He's not railing everywhere. He is simply possibly feeling lower than most. So at this given time, we're going to rule out antipsychotic. Why? It doesn't say any delusions, hallucinations, any disorganized speech. There are some kind of tonic behavior, but doesn't hit one of the first three, which needs to be hallucinations, delusions, or our disorganized speech or thinking. So we're looking at depression or anxiety, and at this time, he was recently released for a suicide attempt. He has low self-esteem. He has great amounts of loss. So we're going to rule out anxiety because it doesn't say excessive worry, muscle tension, irritability, or anything like that. We're looking at Effexor because we need to positively affect his mood because he is experiencing depression. So we need to prescribe an antidepressant. So that's how we look at that question in particular. Question 4. A social worker at a family agency is meeting with the father and his 8-year-old son who has been having issues in school. The father reports that the son's teacher has told him that the boy finds it difficult to complete his work and will often interrupt others while speaking. The boy reports he finds school boring and that he just wants to spend time with his friends. The father would like his son to attend a psychiatric or psychiatrist appointment. What medication is most likely to be prescribed to the boy? A. Vyvanse, B. Buspar, C. Wellbutrin, D. Abilify. And when you have your answer, type happy into the chat. Opening the polls. 20 more seconds. Slapping the poll shut. The majority think it is A. Second place is D. Third place is B and C. Let's look at it. Social worker, family agency, meeting with the father and 8-year-old son, and the kid has been having issues in school. The father reports that the teacher has told him that his son finds it difficult to complete his work and will interrupt people while speaking. The boy says he finds school boring. He just wants to spend time with his friends. The father would like him to attend a psychiatrist appointment. So let's break down our medications. Vyvanse is going to be an ADHD medication. And then Boost Bar is going to be our anti-anxiety. Wellbutrin is going to be our depression med. And then Abilify is going to be a mood stabilizer. So, quick review, family agency, father, 8-year-old son. He's having issues in school. Teacher says that he finds it difficult to complete his work. He's interrupting people while speaking. He finds school boring. He just wants to chit-chat with his friends. So, at this given time, we're going to rule out Wellbutrin because the kid does not sound depressed in any way, shape, or form. No low self-esteem, no lack of interest, no weight loss, no anything like that. So at this time, we're also going to rule out anti-anxiety because it doesn't say the kid's having excessive worry, doesn't say he's avoiding people, doesn't say he's having adverse physiological effects, doesn't say that he's having behavioral issues towards other people. At this time, we're either looking at ADHD or a mood disorder. At this given time, we're looking at an 8-year-old. We're not seeing any mania. We're not seeing any hypomania. We're not seeing any aggressive anger, ODD, conduct disorder, anything like that. So we're going to rule out Abilify, and we are going to be looking at ADHD as the answer. So that's how we look at that question in particular. Question 5. A social worker in an outpatient setting is completing an intake assessment with a 35-year-old male who reports feeling like his friends are out to get him. The man reports that he has not been sleeping well for the past 8 days and that it feels like his mind will not shut off. The man reports spending money that he does not have and that he feels pressured to engage in conversation with everyone he meets. The man reports having a history of hospitalization, that he has been arrested for getting into fights with people. What medication would best treat the man's symptoms? A. Abilify. B. Invega. C. Xanax. D. Zoloft. And when you have your answer, type the word candy into the chat. Opening the polls. 20 more seconds. Slapping the polls shut. The majority think it's A. Second place is C. Third place is D. Fourth place is B. Let's look at it. So we're in an outpatient setting, intake assessment, first time meeting this 35-year-old male. Feels like his friends are out to get him. The man reports that he's not been sleeping well for the last 8 days and feels like his mind will not shut off. Any length of time, jump on it. We'll give you a picture. 8 days ago, this started. Spending money that does not have, and he feels pressured to engage in conversation with everyone that he meets. So 2 different criteria: risky behavior and pressured speech. Having a history of hospitalization. He's getting in the fights with people. What medication is likely to impact this person's situation? Abilify, remember, is a mood stabilizer / anti-psychotic. And then Invega is going to be anti-psychotic. And then Xanax, anti-anxiety. And then Zoloft, we're going to loft the mood for depression. Quick review: outpatient setting, intake assessment, 35-year-old male, feels like friends are out to get him. He's not sleeping well, 8 days, feels like his mind will not shut off, flight of idea, spending money he does not have, risky behavior, feels pressured to getting the conversation, he's hospitalized, he's getting into fights with people. So at this given time, we're going to rule out Zoloft because he doesn't exhibit any depression symptoms at this given time. So we have either anxiety, psychosis, or mood disorder / psychosis. And at this time, he says he does feel like his friends are out to get him. So we have excessive worry at times. It's been going on for 8 days, sleep disturbances, mind's not shutting off, flight of idea, pressured speech, risky behavior. So we're going to rule out an antipsychotic disorder or psychotic disorder, an psychotic med. Why? Because he's not saying he's delusional, hallucinations, disorganized speech, or anything like that. He's either having anxiety or a mood disorder. And with the 8 days, it's pointing more at a mood disorder with that bipolar disorder, and says he's never had a depressive episode, or doesn't say he's a depressive episode. In the situation, we're looking more at our bipolar 1 disorder. Why? Clinically significant impact, hospitalized. Throw anxiety to the side and say he is more along our mood disorder and antipsychotic disorder realm. So that's how we'd break down that question in particular. Question 6. A social worker at an outpatient clinic is working with a 38-year-old female who reports having difficulty sleeping for the past 2 weeks. The one reports that she has been getting a lot of ideas what she can do in her life, and she cannot keep up with them all. The one reports that she has spent all of her money on materials to advance her life and is now at risk for losing her house. The woman has never been hospitalized and denies ever being on medications. What is the most likely diagnosis for this woman? A. Bipolar 1 disorder. 2. Bipolar 2 disorder. C. Generalized anxiety disorder. D. Schizophrenia form. When you have your answer, type the word water into the chat. Opening the polls. 20 more seconds. Slap on the poll is shut. The majority think it is A. Close second is B. Close third is C. No one thought D. Let's look at it. So we're in an outpatient clinic working with a 38-year-old female, reports having difficulty sleeping for 2 weeks. Any length of time, hop on it. It will paint the picture. The woman reports she's getting a lot of ideas where she can do in her life, flight of idea, goal-oriented activity. She cannot keep up with all of them, lack of concentration. And the woman reports that she has spent all of her money on materials to advance her life. And she's now at risk for losing her house. So potentially a clinically significant impact based on risky behavior. She's never been hospitalized and denies ever being on meds. What are we looking at here? Bipolar 1 disorder is again mania or hypomania. And mania is going to be 7 days or longer. And then hypomania, 4 days or longer, does not require an episode of depression and requires a clinically significant impact. So bipolar 2 disorder is going to be hypomania, 4 days or longer. It does require an episode of depression and it does not require a clinically significant impact. Generalized anxiety disorder, 6 months or longer, and then schizophrenia form is longer than 1 month, yet less than 6 months. So quick review, outpatient clinic, 38-year-old female, difficulty sleeping. It's been going on for 2 weeks. She's getting a lot of ideas what she can do in her life. She can't keep up with all of them. She's spending a lot of money to advance herself. She's now at risk for losing her house, never been hospitalized, and she's never been on any medications. So at this given time, we're going to slap generalized anxiety disorder out of the equation. Why 6 months or longer? We're looking at 2 weeks. Doesn't equate to anything. Cannot be the answer. And we're also going to push away schizophrenia form. Why? Because hasn't been going on for longer than a month. She's not talking about delusions, not talking about hallucinations or disorganized speech or the negative symptoms, catatonic, lack of hygiene, isolating self, etc. So we're either looking at A, bipolar 1 disorder, B, bipolar 2 disorder. And at this given time, it doesn't have any depressive episodes in the given question, as well as if someone has spent all of their money, is now at risk of losing their house, that is likely a clinically significant impact on someone's functioning in some way, shape, or form. So we're going to push away bipolar 2 disorder. Why? Because there's no episode of depression and it requires an episode of depression. And this person has a clinically significant impact on their function given they've never been hospitalized. But losing a house is just as significant as being hospitalized. So we're going to go with A, bipolar 1 disorder, based on the fact that it can be mania 7 days or longer and that had that clinically significant impact. It cannot be hypomania because hypomania does not require that clinically significant impact, and it had that clinically significant impact. So that's how we look at that question in particular. Question 7. Social worker out in the community mental health clinic is meeting with the mother and her 9-year-old son who is having behavioral issues at school for the past 6 months. The mother reports that her son has been sent home multiple times for pushing other children while waiting in line, will run around the classroom when completed with his work, and interrupt other people while they are talking. The child reports that he does not like other people and feels like they are too slow and need to stay out of his way. What diagnosis best explains the boy's behavior? A, attention deficit hyperactivity disorder. B, separation anxiety disorder. C, generalized anxiety disorder. D, oppositional defiant disorder. When you have your answer, type the word hopeful in the chat. Opening the polls. Twenty more seconds. Slapping the polls shut. The majority think it is A. Second place is D. Third place is C. No one thought B. Let's look at it. So we're in a community mental health clinic and we are meeting with mother, 9-year-old son. He's having behavioral issues at school in the length of time, 6 months. Any length of time, hop on top of it. It paints that nice little picture. The mother reports that her son has been sent home multiple times for pushing kids while waiting in line, run around the classroom when his work is done, and he's interrupting people while they're talking. The child reports he does not like other people and feels like they're too slow. Get the heck out of my way, he says. What are we looking at in particular? ADHD is lack of patience, not being able to sit still, and appears to be driven by motor and will leave their seat when it is inappropriate. And we are looking at 6 months or longer. Separation anxiety, someone who worries about someone they care about being harmed, fixated on the potential situations that can occur when they are not around, and they become distressed when away from their significant attachment figure. And we are looking at 6 months or longer in adults and 4 weeks or more in children. Generalized anxiety disorder, that's where we're looking at 6 months or longer. And then the criteria we're looking at: irritability, constant worry, muscle tension, lack of concentration, and worrying about multiple things at the same time. Oppositional defiant disorder. Child will be defiant towards people of authority and do not care about respecting others. Quick review. Community mental health clinic. Mother, 9-year-old son, behavioral issues, been going on for 6 months. Her son has been sent home multiple times for pushing other kids, run around the classroom when he's completed, and interrupt people while they're chit-chatting. He does not like other people, and they need to stay out of his way because they are too slow. So automatically going to throw oppositional defiant disorder out of the mix. Why? Because we didn't go it over in this session, as well as he's not just being defiant towards people of authority. He's being defiant towards every single person. Why? Because he's running over people, interrupting people, and doing whatever the heck he wants. So that can't possibly be the answer. So at this given time, is he worried about things in general? Is he worried about being separated from someone? Or is he just having attention deficit hyperactivity disorder with impulsivity in the mix? So at this time, we're going to rule out generalized anxiety disorder because it doesn't say he's worried about things in general. Yeah, he's just getting kind of fidgety and kind of bulldozing people, but that's not the case in this situation. So is he worried about being separated from his mother, or is he just hyperactive at this given moment? So at this time, we're going to rule out separation anxiety disorder because it doesn't say he's worried when he's separated from his mother. He just simply can't sit still. He's interrupting people, not being able to wait in lines, operated on a motor, and he fits the criteria fit the length of time 6 months or longer. So the answer here is going to be attention deficit hyperactivity disorder. That's how we'd look at that question in particular. Question 8. A 21-year-old client has been working with a social worker at a community mental health clinic for the past 3 months. The client reports hearing voices that tell him to hurt his parents, and they have caused him to isolate from social situations. The client reports finding it difficult to sleep and that he feels like someone from his dreams is going to hurt him. The client denies ever being hospitalized and that he can keep his symptoms under control. What would be the most likely diagnosis for this client? A, social anxiety disorder. B, brief psychotic disorder. C, schizophrenia form. D, schizophrenia. And when you have your answer, type the word cup into the chat. Opening the polls. Twenty more seconds. shutting down the poll. The majority think it is C. Second place is B. Third place is D. Fourth place is A. Let's look at it. So we have a 21-year-old client, and we are in a community mental health clinic. And it's been going on for 3 months. Client reports hearing voices that tell him to hurt his parents and that cause him to isolate from social situations. He reports finding it difficult to sleep and feels like someone from his dreams are going to hurt him. And he denies ever being hospitalized. He's keeping his symptoms under control. So, social anxiety disorder, we're looking at 6 months or longer, and they do not engage in social situations or are afraid that they will be criticized or negatively evaluated in some way. And then brief psychotic disorder, less than 30 days with positive and negative symptoms. Schizophrenia form, longer than 1 month, yet less than 6 months. And then schizophrenia, 6 months or longer. And they both have positive and negative symptoms. Quick review, 21-year-old client. We're in a community mental health clinic. It's been going on for 3 months. He's hearing voices, tell him to hurt his parents. He's isolating from social interactions, finding it difficult to sleep. Feels like someone from his dreams is going to hurt him. He's never been hospitalized. He's never had any issues with keeping his symptoms under control. So at this given time, we're going to rule out social anxiety disorder. Why? Because it's not been going on for 6 months or longer. Plus, he's not saying that he's avoiding social situations for the sole fact that he's going to be criticized or anything. He's avoiding social interactions or people due to the fact that he doesn't want to hurt him. And he's experiencing positive and negative symptoms of schizophrenia spectrum. So at this given time, we have 3 months for the length of time. We're going to rule out schizophrenia because it's not longer than 6 months. And we're going to rule out brief psychotic disorder because it's longer than 1 month. So we're looking at the pre-form of schizophrenia due to the fact the length of time, they both have positive and negative symptoms. But at this given time, he is in the window after brief and before schizophrenia. So that's how we look at that question in particular. The length of time bought us the answer there. Question 9. Social workers meeting with a 55-year-old female who reports feeling not like herself. The woman reports that her husband passed away a year and a half ago and that she took it pretty hard. She reports that she did not leave her house for 6 months, did not find pleasure in anything, stopped attending church, and would have missed Christmas last year if her children did not drive to her house and convince her to go. The woman reports that right when she started to feel better, that her daughter was killed in a crash 3 months ago, which brought back all of her depression. What diagnosis best explains what the woman is experiencing? A, persistent depressive disorder. B, major depressive disorder. C, generalized anxiety disorder. D, adjustment disorder with depressed mood. When you have your answer, type one thing in the chat that you're looking forward to in the next week. Opening the polls. Twenty more seconds. Slapping the polls shut. The majority think it is B. Second place is A. Third place is D. Fourth place is C. Let's look at it. So we have a 55-year-old female, reports feeling not like herself. She reports her husband passed away a year and a half ago. Any length of time, hop on top of it. And she took it pretty hard. She reports she didn't leave the house for 6 months. Jump on that length of time as well. And did not find pleasure in anything, stopped going to church, and would have missed Christmas last year. But her children drove and convinced her to go. Woman reports right when she started to feel better, her daughter was killed in a car crash 3 months ago, which brought it all back. So she had 3 months of a length of time without symptoms. So let's break them down. Persistent depressive disorder is 2 years or longer of depressive symptoms and no longer than 2 months without symptoms. Major depressive disorder, 2 weeks or longer of depressive symptoms. Generalized anxiety disorder, 6 months or longer. And then adjustment disorder with depressed mood is symptoms within 1 to 3 months of an event, but not longer than 6 months. And the reaction to the adjustment is beyond what is normally expected. Quick review: 55-year-old female, not feeling like herself. Her husband passed away a year and a half ago. She took it pretty hard. She didn't leave the house for 6 months. She didn't find him pleasure in anything, stopped going to church. Her children convinced her to go to Christmas. She was feeling better for 3 months until her daughter got into a car crash, which brought back all of her depression. What diagnosis best explains what she's experiencing? So at this given time, we're going to throw adjustment disorder with depressed mood right out the window because it would have been relevant if the question stopped here. But it continued on. She didn't leave the house for 6 months, and that would have been kind of an adjustment thing. Someone passed away, you isolate for that long, but her depression continued on longer than that. We're going to rule out generalized anxiety disorder. Why? Because she didn't experience any anxiety in any way, shape, or form. So we're either looking at major depressive disorder or persistent depressive disorder. And the tricky thing is she never really met criteria for persistent depressive disorder because it's 2 years or longer, and she had an absence of symptoms longer than the 2-month period that were allotted. So we're going to throw persistent depressive disorder right out of the window because it was persistent, but not as persistent as we needed it to be. So we're looking at major depressive disorder as our answer. So that's how we look at that question in particular. Question 10. Social worker in an outpatient clinic's meeting with a 29-year-old male for concerns of excessive anger. The man reports that whenever he's away from his wife, that he will constantly worry about her, and he feels that someone is going to hurt her. The man reports he calls her phone constantly, which has caused arguments in their relationship. The man reports that he cares about his wife and is unsure how to improve his situation to stay in the relationship. What is the most likely diagnosis for the man? A, generalized anxiety disorder. B, separation anxiety disorder. C, social anxiety disorder. D, panic disorder. And when you have your answer, type one thing that you learned from this session tonight. Opening the polls. Twenty more seconds. Shutting down the polls. The majority think it is B. Second place is A. No one thought C or D. Let's look at it. So we have a social worker, outpatient clinic, meeting with a 29-year-old male, concerns of excessive anger. The man reports whenever he's away from his wife, he constantly worries about her and feels like someone is going to hurt her in some way. The man reports he calls her phone constantly, which has caused arguments in the relationship. Man reports he cares about his wife, unsure how to improve his situation to stay in the relationship. Generalized anxiety disorder, 6 months or longer, which involves irritability, constant worry, lack of concentration, worrying about multiple things at the same time, and easily fatigued. Separation anxiety disorder, someone who worries about a significant figure in their life, and it is triggered when they are away from the person. They fear that the person will be harmed in some way, and they become distressed when away from them. Social anxiety disorder, 6 months or longer. And let's do our due diligence of separation, 6 months or longer. And then within social anxiety, remember, key emphasis on social. When someone becomes worried about being criticized or negatively evaluated by others in social situations. Panic disorder, physiological symptoms associated with anxiety and fear of having a panic attack. And remember, that's the super weird one of 30 days or less, because it's just oddball. But quick review: outpatient clinic, 29-year-old male, concerns of excessive anger when he's away from his wife, that he constantly worries and feels that someone's going to hurt her. The man reports he calls her phone constantly. It's caused arguments. He wants to improve the situation in some way, shape, or form, and he wants to get the job done. At this time, is he anxious in general? Is he anxious when he's separated from someone? Is he anxious in social situations? Or is he afraid that he's going to have a panic attack or be afraid in some way, shape, or form? So at this given time, we're going to throw away panic disorder because it doesn't list any physiological sensations, and it doesn't give that specifier of 30 days or longer. There's no length of time in this situation, so we can't jump on it, and our painted picture is absent at this time, so we have to do it based on what's going on in the situation. So we're going to rule out generalized anxiety disorder because he's not anxious about anything in general. It's always when he is away from his wife that he becomes worried, which it doesn't list any social situations besides him trying to reach out to his wife, but she gets pretty angry about it. So we're going to rule out social anxiety as well, because he's not anxious about being negatively scrutinized. He is being negatively scrutinized by his wife, but not to the fact where he's worried to engage with her. So it's going to be separation anxiety disorder in this situation. So that's how we look at that question in particular.